Chapter 13, Pharmacy Billing and Inventory Management. We'll skip over the key terms and definitions because we will cover them in the chapter. Everyone working in the pharmacy is responsible for maintaining the inventory stock. This is an essential part of the daily tasks of pharmacy staff. As stock is depleted, it is important to reorder replacement inventory. One method of replenishing the stock is just-in-time ordering. This is an inventory strategy in which medications are ordered and received only as they are used. Along with reordering stock, pharmacy technicians help manage the third-party billing process. Knowledge of proper billing procedures is a skill that normally is learned by experience over time as a technician in the pharmacy. So for sure, this is one thing you will not master in a couple days, maybe even in a week. You might, after 1 or 2 weeks, know how to put in your most common insurances, but you will deal with issues and stuff like that for your first couple years and then a little bit forever. Because each pharmacy contracts to accept different insurance companies, the technician must be acquainted with the normal billing procedures of that particular pharmacy and its associated insurance companies. A formulary is analogous to a backbone. The formulary is a list that describes all the medications covered under a specific insurance plan approved for use in an institution such as a hospital. It may also offer alternative medications if the first choice is not covered. For medications to become part of a formulary, they must meet certain requirements, such as effectiveness and cost. These are determined by pharmacists, pharmacy technicians, physicians, nurses, and administrators who are members of the Pharmacy and Therapeutics Committee team. An institution can have an open formulary, which means any drug can be ordered and stocked for patient use. A closed formulary places certain restrictions on the drugs ordered. Each insurance company has its own formulary with recommendations for therapeutic alternatives when a drug is not covered under a particular plan. A hospital or home health care pharmacy is more likely to have a closed formulary or a specific list of drugs to be kept on hand and dispensed to the patients and health plans served by the pharmacy. Drug utilization, formerly known as drug utilization review. So now it's called the DUE. When I first started out in pharmacy, it was called the DUR. It's an important process in ensuring that the correct drug is prescribed for the correct condition. Pharmacists must perform this function, but pharmacy technicians also play a huge role in this process. So when we are inputting prescriptions, an alert can interrupt the process if a drug interaction or duplicate therapy is found. We must never override these warnings on the computer. They must notify the pharmacist immediately so he or she can screen the medication order for potential problems, such as a drug-drug interaction, duplicate therapy, or other possible errors. Many formulary drugs are generic versions of proprietary brand name products. These drugs are often as effective as the brand name drugs. They meet the same bioequivalency requirements but are less expensive. Although most insurance companies cover most of the cost of a generic drug, some do allow the patient to choose the brand name drug. However, if the patient selects the brand name drug, he or she is responsible for the amount due based on calculation of the copay as aligned in their third-party agreement. For example, if the normal copay is $5 per prescription and the patient chooses a brand name that costs $10 more than the generic equivalent, the patient must pay $15. The dollar amount of a prescription also depends on orders being written in DAW and other specialty codes. So DAW 0 indicates the physician authorizes a therapeutic alternative and the pharmacy can dispense the generic drug to the patient. DAW 1 indicates DAW and is usually used by the physician to indicate that the trade or brand name medication is in some way medically necessary for the successful treatment of the patient. DAW 2 indicates that the physician has approved the generic substitution of the medication prescribed. And there's other DEA codes that are used less frequently that we will go over at some point. The terms trade, brand, and proprietary are used interchangeably to refer to the name of a drug product that was first patented and marketed by the owner or manufacturer. Another name for such a product is called an innovator product. After a certain time passes, the patent expires. Eventually, other drug companies can apply for the right to produce the same drug product, although not all drugs will be available in generic form. For example, it is usually not advantageous to drug companies to make generic medications that are used by a small percentage of the population. All right, so now we have types of private and group medical insurance plans. So we have the CHAMP VA card, the drug discount card, that's just like those little cards that the patient have from the manufacturer. A Medicaid card, a medical insurance ID card, a Medicare Advantage, a Medicare card, a Medigap card, pharmacy benefits card. So if you're ever confused if it's pharmacy or if this is health or it's both, either way, if it's pharmacy, it's going to have RX printed somewhere on it. A pharmacy coupon card provided by the drug manufacturer, TRICARE, and healthcare and workman's compensation where no card is required. A health maintenance organization, which is an HMO, has specific features that distinguish it from traditional insurance plans. It's an effective measure for controlling healthcare costs. So for these, they include having a pharmacy care physician. It requires that you choose a primary physician to coordinate all of your medical needs. An IPA, an individual or independent physician association. Copays, and capitation. If a patient has HMO insurance, the technician must obtain information from the patient, such as address, date of birth, insurance number, and full name. The pharmacy bills the insurance company first through online adjudication and receives an authorization number and copay information for the patient. Adjudication is the processing of claims over a computerized system. If the insurance claim is rejected, the pharmacy either must troubleshoot the issues or have the patient pay full price for the medication. It is then the patient's responsibility to contact the insurance company and attempt to obtain reimbursement. The patient is responsible for the entire cost only if the insurance company denies coverage based on eligibility or authorization not received before service. HMOs may require prior authorization on certain medications per their formulary guidelines. The prior authorization must be entered in the system before payment is approved. For an example, Botox, it's used to treat muscular disorders, but it's also used cosmetically. So for using it to treat for muscular disorders, we will probably need a prior authorization. There are opportunities to specialize and work specifically as a prior authorization tech. These technicians are considered experts in prior authorizations and provide customer service support to members, customers, and/or providers. A PPO provides healthcare for members at a discounted fee. The benefit is that the patient can choose a physician from the insurance plan of contracted providers or may choose to consult any specialty physician without PCP referrals. There are no requirements to choose a specific PCP. Aetna, Anthem, United Healthcare, State Farm, and other also offer PPO plans. Excuse me. Members of a PPO may have to meet a yearly deductible, the amount that the patient must pay before the insurance company pays. All right, so for our pharmacy perspective, the billing processes for billing an HMO and PPO are similar. It gets a little bit different when we're doing paper billing for like supplies and stuff, depending on what you do as a pharmacy technician. But for the most part, it shouldn't have any kind of effect on how you normally bill. You'll just get their copays. Programs such as Medicare and Medicaid are examples of state managed and federal managed medical insurance plans. Each employee in the United States pays the government a percentage of his or her income toward Medicare. A percentage of each state budget is applied toward Medicaid. Each plan has specific guidelines that must be followed precisely for patients to qualify for reimbursement. Both Medicaid and Medicare were implemented in 1965. Medicaid provided health care services to low-income children, the elderly, the blind, and people with disabilities. Until 1977, Medicaid was associated with the Social Security Administration. Later in 1986, coverage was expanded to infants and pregnant women with low incomes. The following year, many revisions are made, including increasing the eligibility age of children and covering certain individuals who are disabled or unable to return to work. In 1966, more than 19 million people enrolled into the newly formed Medicare program. So box 13.1 shows you the different parts of Medicare. Part A covers institutional costs if the participant meets the criteria established by federal and state regulations. Part B covers the physician and other outpatient services, including a diabetes testing, physical therapy, and other preventative costs. Part C, also known as Medicare Advantage, this is an optional plan to parts A and B. It is a private plan that uses Medicare and must be equivalent to coverage provided by parts A and B. Some Part C plans cover certain prescription drugs. A person should have either Part C or Medigap because the two are not cumulative in coverage. Part D specifically covers prescription drugs. So in the retail pharmacy world, that is going to be the number one Medicare plan you're taking. They will try to give you their red, white, and blue Medicare card all the time. They just don't understand there's different parts that will not cover prescription drugs. He covers some testing supplies and some medications if the patient's had a transplant, but for the most part, no. Part D is going to cover the medication. So it's provided by an individual private insurance plan that's overseen by Medicare. A monthly premium is paid, and the plan chosen by the patient may have an annual deductible. Once the deductible has been paid, the insurance plan pays either all or some of the remaining cost. After the maximum benefit has been reached, there is a gap in the coverage of drug costs, and the patient must pay for prescriptions out of pocket. So you will come to learn this term called the donut hole. And people that are on Medicare use that phrase, and that's when they have that gap in coverage. So if they have a lot of expensive prescriptions, this can happen quite early in the year. So they just want to make sure that they're picking out the right amount of coverage that they need. In 1987, both Medicare and Medicaid required health providers to include patient privacy provisions if they were to participate in the government-sponsored programs. Medicare revised its coverage in 1988, implementing prescription drug benefits, along with a cap on patient liability. In 1996, the Health Insurance Portability and Accountability Act, HIPAA, provided new rules for improving portability, continuity of coverage, and simplified standards for electronic transactions, among other changes. In 1997, Medicare implemented additional changes, including the following: expanded education, expanded preventative benefits, 4 new payment systems for services, including home health care, hospital outpatient and rehab, inpatient rehab, skilled nursing facility services. A significant change was made in 2003 with the Medicare Modernization Act and the creation of prescription drug discount cards, which allowed competition between health plans benefiting participants. In 2006, Medicare Part D was enacted. This requires the federal government to provide subsidies to participants whose income is less than 150% of the federal poverty limit. So table 13.1 shows a chronological changes in Medicaid and Medicare coverage. So kind of interesting. You can read through these and the different laws. I'm not going to go over all of them individually there. Medicare is a federally sponsored program for seniors, the disabled, and for patients that are on dialysis. It functions like an HMO and a PPO. A patient must see someone who accepts Medicare, but the patient has a yearly deductible and a percentage share of the cost. So again, Medicare Part A is for hospital. It covers inpatient care in hospitals, skilled nursing facilities, and critical care hospitals. Part B pays for physician services and outpatient care. It helps pay for services that Part A does not cover, such as durable medical equipment and even physical and occupational therapist when deemed medically necessary. This coverage is optional and most people pay a monthly premium. Medicare Part C is Medicare Advantage, which allows the participants in A and B to obtain additional insurance through private HMOs or PPOs. The Part D plan is for prescriptions and it provides medication drug plan to people who are eligible for Medicare, and it covers medications, insulins, vaccines, and certain medical supplies. Medicare services were expanded in 1980 with the creation of the Medigap plan, which is also regulated by the federal government. The traditional Medigap plan offers optional insurance policies that can be purchased through privately owned insurance companies. The plans are intended to fill the gap in the Medicare program coverage. However, if you have Medicare Part C, Medigap cannot be used. There are 12 different Medigap policies labeled A through L. Most of the insurer plans do not differ significantly in their policies. Each person must purchase his or her own policy. Medicare is the primary payer and the Medigap carrier is secondary. There is also a 6-month open enrollment period for Medigap coverage. Pharmacies must apply for a national provider identifier from the CMS for you to accept Medicare insurance. Here is a sample Medicare Part D card. And box 13.3 lists various supplies covered by Medicare. So all those different things. Medicaid is a federal assistance program based on income and other circumstances. Individuals earning below the national poverty level are eligible for healthcare services. Each state has its own Medicaid program for low-income residents. This also includes uninsured pregnant women and those with certain disabilities. Medicaid is funded by both the state and the federal government. Medicaid can be used with Medicare if the person qualifies. The patient should not be responsible for any costs. If they do, it should be very low. Share of cost, it may require that they pay a deductible before the insurance kicks in. Geographical managed care programs are available to help with better coverage and care. Effective in 2014, Medicaid benefits were expanded to include individuals ages 19 to 65 with incomes up to 138% of the federal poverty level. For a single person, that translates into an annual income of $15,856. This change opened up Medicaid. States must provide certain mandatory benefits for Medicaid participants, such as family planning, home health services, physician services, and smoking cessation for pregnant women, among others. States can also choose to provide optional benefits for Medicaid participants, such as chiropractic services, dentures, eyeglasses, and prescription drugs. TRICARE is a healthcare program for military personnel and their families. This includes approximately 9.6 million active duty service members, National Guard and Reserve members, and retirees. TRICARE is managed by the Defense Health Agency and covers beneficiaries in the Army, Navy, Marines, Air Force, and Coast Guard. TRICARE eligibility is tracked through a worldwide database known as the Defense Enrollment Eligibility Reporting System. So A is a TRICARE Prime card and the B, this is the active duty card for somebody that is in the Army currently or in any armed services currently. The Civilian Health and Medical Program of the Department of Veterans Affairs is a health benefit program in which the VA shares the cost of certain healthcare services with eligible participants. So there's a CHAMP VA card. Workman's compensation is a type of insurance paid by employers to entirely cover injuries suffered by employees while on the job. Federal law requires employers with a certain number of employees to offer workman's compensation. Insurance coverage is provided by private insurance carriers. Anyone who works for a company that pays in a workman's comp may be eligible to use the insurance if he or she has a work-related injury. The patient does not have to pay anything. Instead, claims are filed electronically or on hard copy to the insurance companies. If the patient arrives at the pharmacy with a workman's compensation claim, it is important to obtain billing information before dispensing medication. This may involve contacting the patient's employer, obtaining the billing information over the phone from their human resources department, and then calling the workman's compensation insurance company for further information. The term third-party billing refers to the portion of payment reimbursed by insurance companies. The three entities that are responsible for payment include the patient, the pharmacy, and the insurance company. Because there are so many different insurance companies, each with different billing requirements, it often takes more than 1 year for a technician to become proficient in third-party adjudication or claim building. The information needed by insurance companies to process a claim for the pharmacy or to reimburse the patient is the same information required on a pharmacy label, plus the date of birth, insurance group number, and identification number. So table 13.2 shows the minimum information required by insurance companies. Pharmacies that send claims electronically to an insurance company participate in point of sale billing, which is POS billing. The insurance company verifies eligibility, identifies covered drugs, prices a claim, and returns a response to submitting pharmacies within seconds during the prescription processing functions. So often an insurance company pays for medication only if a prior authorization is first received. Prior authorization is needed for a variety of reasons. For example, the drug of choice may not be included in the patient's formulary, or the insurance company may have determined that less costly methods of treatment are available and the patient must use those first. Two types of forms are used for this: a prior authorization form or a treatment authorization request form, which we call TARS. Most insurance companies require a prior authorization form. The pharmacy typically does not contact the insurance company about the prior authorization. We would normally contact the physician office, and then they would contact the insurance company to request the prior authorization. However, if you work in a specialty pharmacy or a pharmacy where that's your job to do that, you will be the one working with it. The physician often must produce documentation explaining why a specific course of therapy is needed, such as the patient tried other therapies and they were ineffective. The patient has allergies to certain medications, or the patient must undergo diagnostic tests that require the requested therapy. Information included on a prescription card. So we need to have the RX BIN, the pharmacy benefit international identification number, the PCN, the RX group, the identification number, the person code, date of birth, and the sex code. Each pharmacy has its own specific computer system which details each patient profile. Figure 13.6 shows an example of a pharmacy patient profile database and everything that's required here. If the patient has insurance, determining the guidelines of the program of primary importance of the pharmacy is to receive reimbursement. The average wholesale price can be found in the Drug Topics Red Book, or this information may be contained in a portion of the pharmacy database. A copay is a relatively small fixed fee required by the health insurer to be paid by the patient at the time of each office visit, outpatient service, or filling of a prescription. When handling a patient's medication claim, the pharmacy technician may be responsible for using the insurance company's claim form to relay the necessary patient information. Because each company requires its forms to be filled out entirely and correctly, the technician must know the specific needs of the company. Universal claim forms are used in certain circumstances. So that's what this is. A prescription may not be covered for the insured patient for many reasons. For example, the NDC, the National Drug Code, may not be covered. The NDC number is organized into 3 sections: the labeler code, the product code, and the package code. All medications have an NDC number, so even your over-the-counter medications, if you're to go home and look in your medicine cabinet or closet, you will see that even on over-the-counter medications. When a prescription is not covered, it can be frustrating for both the patient and the technician and even the insurance company representative. So other common reasons that a prescription may not be covered. Coverage has expired, coverage limits have been exceeded, patient is trying to refill the prescription too early, the information we got from the card holder does not match the processor's information, among many other things. Patients are often unaware of why coverage has been discontinued and may want the pharmacy to investigate. So if you bill their insurance and it says no longer active and they're like, hey, I should be blah, blah, blah. You can't call. If you call, they're not going to give you any personal information about the patient. So you should not call the insurance company about those types of inquiries. About the only thing that they could ever tell me was like what day it was stopped on. But even then I would, seek judgment on that. The phrase limitation of plan exceeded refers to a patient who has exhausted his or her pharmacy benefits for the specified time period or quantity limitation of a drug. If a prescription requires a greater quantity of the drug than is allowed by the insurance plan, the plan limits are exceeded. For example, some government insurance plans limit the number of prescriptions that can be filled per month or per year. If the prescription is written for a specific quantity of medication that exceeds the maximum amount to be filled per day, the prescription is rejected, and the patient must contact the insurance company for special permission to obtain the drug. Limit exceeded could also mean that the patient has met a yearly or lifetime benefit amount. Formularies tend to be specific. This includes the decision on which drugs are included in the member's plan. These drugs are identified by their NDC, a code assigned to every drug in the United States. If the code submitted is not on the formulary, the claim is then rejected by the insurance company. In pharmacy, these types of medications are referred to as non-formulary drugs. In this case, 2 options can be explored. First, the pharmacist can contact the physician and request that the prescription be changed to a drug that is covered under the patient's insurance plan. Second, the physician can submit a prior authorization form to the insurance company indicating why the patient must take the non-formulary drug. Patients can attempt to have their prescriptions refilled when they still have medication remaining for several reasons. Most of the time, it is not a problem to obtain a refill 1 week before the prescription's refill date. However, there are instances in which the patient may request a refill as early as 1 week after having the prescription refilled. For example, the patient may be leaving the country for an extended period of time and wants to ensure that sufficient medication is available until he or she returns. Most insurance plans allow extra fills in circumstances such as vacations or the occurrence of devastating events. For example, when Hurricane Sandy devastated the east coast of the United States, many insurance companies allowed early refills and replacement fills on prescriptions and even permitted patients to be treated by physicians outside their medical plan. If the patient's insurance will not pay, the patient is responsible for the cost of the medication. Prescriptions normally are written for a 30, 60, or 90-day supply, depending on the condition treated. Mail order companies usually fill up to a 90-day supply for certain maintenance drugs, such as diabetic or heart medications. Sometimes the amount of medication prescribed is limited because of the safety or legal issues regarding the dispensing of a specific medication. Because certain medications are dangerous, they may not be prescribed for more than 30 days. Examples include Drug Enforcement Administration Schedule II controlled substances and a specific drug, isotretinoin, which is an acne medication, which has been linked to teratogenicity if given to pregnant women. Many insurance plans allow additional savings if refills are ordered via mail order that are on the list of participating pharmacies. Sometimes an insurance company mistakenly rejects a valid claim. When this happens, the pharmacy technician must submit the claim. Sometimes you might have to call them. Often insurance carriers enact plan limitations to control use and reduce drug costs. Some examples include maximum amounts of medication that can be dispensed at one time, day supply restrictions, like 30 and 90 days, refill limits requiring prior authorization for certain medications, step therapy. So just a little note, fraud involving pharmacy insurance claims is a serious issue and should not be taken lightly. Falsely billing charges for medication that was not dispensed is a crime. Some patients do not have insurance coverage and are solely responsible for their prescription costs. These patients can pay with cash, check, credit, or debit cards. Patients can obtain drug discount cards from a variety of sources. These do not offer insurance benefits, but instead allow the patient to obtain medications at the contracted provider rate. For example, if a drug discount card contracts with a pharmacy to pay the AWP 10% plus a $2 dispensing fee for a drug that would normally be sold at retail for AWP plus 15% plus a $5 dispensing fee. The patient can obtain the medication at a less expensive rate through a prescription drug card. Health savings accounts and flexible spending accounts are something like a savings account that can be used to pay medical bills before a deductible has been met, along with copays for prescriptions and office visits. Proper inventory management is the key to an efficiently run pharmacy. Having the needed medications and supplies on hand to serve the patient's needs is a top priority. Minimizing the carrying costs of the pharmacy's inventory investment enhances the pharmacy's ability to earn a profit. Everyone working in the pharmacy is responsible for maintaining the inventory stock. This is an essential part of the daily tasks of pharmacy staff. As stocks are depleted, it is important to order replacement inventories. Each pharmacy orders drugs that include formulary drugs and a limited amount of non-formulary drugs or less commonly used drugs. The established level of medication stock kept on hand at any given time is referred to as the PAR level, the periodic automatic replenishment level. Most hospitals have a technician who is in charge of maintaining stock levels and completing the special ordering of medications. The technician who orders the stock is responsible for the actual ordering, billing, and restocking of the pharmacy shelves. However, it takes a group effort in the pharmacy to maintain stock levels and avoid having to borrow items from another hospital or special order them at a higher cost. A third method of stocking requires each item to be tagged with a manufacturer's sticker as it arrives in the pharmacy. Stickers are provided by the manufacturer and must be affixed to each item before it is placed on the shelf. The sticker lists the stock number of the medication along with the price. When an item needs to be reordered, the sticker is taken off the container and placed on an ordering sheet, also known as a want book. It is then entered into an electronic device for transmission by phone or by online ordering. That's really kind of like an old practice. You don't see that done too much. Every day, the pharmacy depletes some of its stock of drugs and supplies. Although pharmacies have different systems of ordering the medications, most orders normally are placed by using a computer. When the shipment arrives, all included medications and supplies must be verified against the inventory list. Initialing and writing received on each invoice is important. Some medications are back ordered, and these items are currently not in stock from the manufacturer but will be sent as soon as they are available. Placing stock on the shelf is important duty of the pharmacy technician. It is the point at which the stock is rotated. Placing medications with later expiration dates farthest back on the shelf ensures that the medications with the earliest expiration dates are being used first. The inventory technician is also responsible for returning damaged items and expired agents and handling recall items according to the manufacturer's guidelines. Maintaining a par level in the pharmacy is important for several reasons. Many manufacturers do not fill orders on weekends or holidays. Thus, if the pharmacy depletes its stock during this time, it may have to wait until the following delivery day to receive the necessary stock. When a pharmacy does not carry a medication, perhaps it is new or uncommon, it may be ordered from a drug wholesaler. Most pharmacies rely on computerized systems that are programmed to order medications. This is by far one of the best ways to maintain appropriate stock levels, although not all pharmacies have this system. Most manufacturers identify their products with barcodes that can be scanned. This process accelerates the input of information because one pass of the barcode device identifies the drug, strength, dosage form, quantity, cost, package size, and other information necessary to fill the medication or the device. Automated dispensing systems involve technology designed to reduce labor and increase patient safety. ADS store medications and control electronic dispensing. In addition to the inventory status, such units also monitor controlled substance use and inventory, and all individuals adding drugs to or taking from the unit are identified, and a log is kept for all users. This also ensures the proper use of controlled substance and detects any discrepancies. So there's one right there. Although manual ordering is being eliminated as the pharmacy is moving more towards a technological field. This is an old ordering technique, but it is still used. And it's important to monitor stock levels. Sometimes I know when I worked at the pharmacy, we had a printout of all the stuff that it manually ordered, and some stuff would be missing. We'd have to add it in. Otherwise, we just wouldn't get it the next day. Stock normally arrives daily at the pharmacy from different sources. For billing purposes, it is important that all stock be checked completely against the packing list when first received. 13.1 shows the procedure on receiving stock in the pharmacy. So you can read through that. As stock arrives, it is important to follow the manufacturer's requirement for storage. Certain medications must be frozen at temperatures between -20 degrees Celsius and -10 degrees Celsius. Refrigerated at temperatures between 2 degrees Celsius and 8 degrees Celsius, or stored at room temperatures 23 degrees Celsius. Medication is returned to the warehouse or manufacturer for 4 main reasons: drug recalls, class 1, 2, and 3. Class 1 is for drugs that pose a serious threat to users' health or even death. Class 2 recalls for drugs that may cause a temporary health problem and have a low risk of creating a serious problem. Class 3 recalls for drugs that violate FDA regulations concerning container defects or have a strong taste or color. 2, damaged stock. 3, expired stock. and 4, medication is about to expire, the pharmacy may return the drug to the wholesaler for credit or full price if the drug has at least a 9-month expiration date later than the date of return. Many manufacturers are required by law to recall any product that has been found to violate any of the following guidelines. Labeling is wrong, product was not packed or produced properly, drug batch was contaminated, the FDA has required removal of the drug from the market as a result of safety risks, and any other change that occurs that causes the drug to fall outside the FDA or manufacturer's guidelines. Recall notices can arrive at the pharmacy by mail, email, or fax. So just make sure that you know the proper procedures for your pharmacy. I know when I worked at a large chain pharmacy, we didn't pay any attention to any recall notices unless they were given by our company themselves from the FDA or whatever source. Box 13.5 shows a recall notification for a medication, the vancomycin for injection. So you can read through that and see everything that's kind of listed in that. If you notice that some drugs are damaged en route to the pharmacy, but you are not aware of damage at the time of delivery, it is not too late to return the damaged stock to the manufacturer. It may be necessary to first contact the manufacturer and obtain an authorization before the damaged goods are returned. Some pharmacies may have a policy to pull any medication that expires in 3 months or sooner. This ensures that no drugs on the shelf are close to their expiration date. Depending on the contract between the pharmacy and the manufacturer, it may be acceptable to return items as long as they can be bundled into a minimum package size rather than as partials. Patients should be instructed in the proper disposal of unused medications. For many drugs, it is advisable to mix them with either coffee grounds or kitty litter and then place them in the garbage. Medication should never be emptied into a toilet or drain because the drugs can infiltrate the water supply. Also, just another thing, medications taken out of the pharmacy by a patient cannot be returned to stock. There is some times where that doesn't really go, but if a patient takes a medication that's $200, goes home and thinks about it and says, I don't have $200, I'm gonna take this back. We can't do that. Many items cannot be returned to manufacturers. Some examples are drugs that are reconstituted or compounded, partially used bottles of any medication, and any drugs that have been repackaged by the pharmacy. In addition to regular inventory returns, technicians must routinely check patient medications ready for pickup that have been left. They may be not picked up because of unknown changes in medication, hospitalizations, or costs. Those that were charged to insurance must be reversed to the third party by electronic submission to credit the patient and remove the prescription from the insurance. Once the completed prescriptions are removed, names and other pertinent information are blacked out and placed in a HIPAA container, and then we can return the medications to stock. When ordering supplies for the pharmacy or stock for the pharmacy, the technician orders from a centralized warehouse the pharmacy owns, from a wholesaler, or directly from the manufacturer. Prime vendors are large distributors of various medications and retail products to pharmacies. Wholesalers are companies that stock a variety of drug manufacturers' medications and normally have a just-in-time turnaround for ordered drugs. Direct manufacturer ordering may be used under certain circumstances. For example, a group of pharmacies may join a group purchasing organization that contracts with the manufacturer for better pricing. Table 13.3 lists the difference in ordering from manufacturers, wholesalers, and warehouse repackaging plants. Some special considerations apply to a host of drugs ordered by a pharmacy, such as controlled substances, investigational drugs, cytotoxic drugs, and hazardous substances. Each of these types of medication requires special ordering, inventory, storage, handling, and return documentation. The DEA requires special forms to be completed for ordering, transferring, and returning Schedule II controlled substances. Investigational drugs typically have documentation that must be completed and returned to the manufacturer each time a medication is dispensed. These drugs are stored and inventoried separately. Cytotoxic drugs do not need special documentation, but they should be handled with great care and placed in a safety cabinet according to the manufacturer's guidelines. Most pharmacies stock certain chemicals that are considered hazardous. You must know where the safety data sheets of your pharmacy are located in case of a spill. Agents such as phenol should be stored behind cabinet doors to protect individuals from accidentally knocking the bottle off a shelf and inhaling the toxic fumes or coming in contact with the agent.